Hello and welcome to Doc AT. In today's video, we're diving into the new topic of congestive heart failure. What it is, its pathophysiology, risk factors and causes, diagnosis and treatment. Let's break it down together. Congestive heart failure is a condition where the heart cannot pump enough blood to meet the body's needs or manage venous return without raising pressure inside the heart. This happens due to issues like weakened heart muscle, problems with valves, or thickened walls of the heart. These problems lead to fluid buildup in the lungs and body, poor blood flow to organs, and symptoms like breathlessness and fatigue. Congestive heart failure can happen suddenly or develop slowly over time, with symptoms varying in severity depending on the underlying cause and stage of the disease. Etiology. Congestive heart failure occurs due to various underlying causes, which can be categorized as ischemic causes. Coronary artery disease, the most common cause of congestive heart failure, primarily due to myocardial infarction or chronic ischemia. Reduced blood flow leads to scar formation, weakening the heart muscle and causing systolic dysfunction. Post-myocardial infarction remodeling, progressive thinning, dilation, and weakening of the ventricular wall following an infarction, often exacerbated by neurohormonal activation. Non-ischemic causes. Hypertension. Prolonged high blood pressure leads to left ventricular hypertrophy, impaired diastolic function, and transition to heart failure with preserved ejection fraction. Valvular heart disease. Aortic stenosis. Elevated afterload due to obstruction of left ventricular outflow. Mitral regurgitation. Chronic volume overload that promotes left ventricular dilation and reduced systolic function. Primary cardiomyopathies. A dilated cardiomyopathy may arise from genetic factors, alcohol abuse, viral infections, or cardiotoxic drugs, e.g. anthracyclines. Hypertrophic cardiomyopathy. Genetic mutations in sarcomeric proteins causing increased myocardial contractility, diastolic dysfunction, and susceptibility to arrhythmias. Restrictive cardiomyopathy. Associated with infiltrative or fibrotic diseases like amyloidosis, sarcoidosis, or hemochromatosis. Arrhythmias, persistent tachycardia or uncontrolled atrial fibrillation, contributes to functional deterioration of the myocardium. Congenital heart diseases. Structural abnormalities such as ventricular septal defects, patent ductus arteriosus, or tetralogy of Fallot. Other contributing factors. Endocrine disorders. Conditions such as hyperthyroidism, hypothyroidism, and pheochromocytoma disrupt myocardial performance and hemodynamics. Toxins. Chronic alcohol use, cocaine abuse, or exposure to cardiotoxic agents like chemotherapeutics. Infections. Viral myocarditis or parasitic diseases such as Chagas disease. Pregnancy-related conditions. Development of peripartum cardiomyopathy due to hormonal and hemodynamic stress during late pregnancy or postpartum. Classification heart failure. Based on ejection fraction. Ejection fraction is a critical parameter for categorizing heart failure and guiding management. Heart failure with reduced ejection fraction. Ejection fraction less than 40%. This form is often associated with impaired systolic function due to conditions like ischemic heart disease or dilated cardiomyopathy, ventricular dilation. Patients benefit from therapies targeting neurohormonal pathways, such as ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. Heart failure with mid-range ejection fraction. Ejection fraction 41 to 49% with mixed features of systolic and diastolic dysfunction. A transitional category with overlapping features of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. These patients may benefit from therapies used in heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction. HFpEF greater than or equal to 50%. Commonly linked to diastolic dysfunction, increased myocardial stiffness, and high filling pressures. It is prevalent in older adults and those with comorbidities like hypertension and obesity. Management focuses on symptom control, treating comorbidities, and lifestyle interventions. Based on anatomical and clinical features. A left-sided heart failure involves pulmonary congestion, dyspnea, and reduced systemic perfusion. A right-sided heart failure causes systemic venous congestion, ascites, and peripheral edema, often secondary to left-sided failure or pulmonary hypertension. Biventricular heart failure, a combination of left and right-sided failure, common in advanced disease stages. Based on temporal onset. Acute heart failure, rapid decompensation with severe congestion or hypoperfusion. Chronic heart failure, slowly progressive disease with periods of compensation and decompensation. Chronic heart failure may acutely worsen, acute decompensated heart failure. Based on New York Heart Association classification. The New York Heart Association classification is widely used to describe functional limitations in congestive heart failure. Class 1, no limitation of physical activity. Ordinary physical activity does not cause symptoms of heart failure. Class 2, slight limitation of physical activity, comfortable at rest and mild exertion but ordinary activity results in symptoms. Class 3, marked limitation of physical activity, comfortable at rest but less than ordinary activity causes symptoms. Class 4, unable to carry out any physical activity without discomfort. Symptoms of heart failure are present even at rest. Pathophysiology, myocardial injury or stress. The initial insult, e.g. ischemia, pressure overload, triggers a cascade of maladaptive changes, including neurohormonal activation. Increased sympathetic nervous system activity raises heart rate and systemic vascular resistance, but chronic activation causes myocardial fibrosis, arrhythmias, and apoptosis. Activation of the renin-angiotensin-aldosterone system, RAS, increases preload and afterload, further straining the heart. Ventricular remodeling, myocyte hypertrophy and interstitial fibrosis. Chamber dilation in heart failure with reduced ejection fraction or concentric hypertrophy in heart failure with preserved ejection fraction. Hemodynamic consequences. Systolic dysfunction. Impaired myocardial contractility reduces stroke volume and cardiac output, leading to compensatory mechanisms like increased heart rate and peripheral vasoconstriction. Diastolic dysfunction. Stiff ventricles hinder relaxation and filling, causing elevated left atrial and pulmonary pressures, leading to pulmonary congestion and dyspnea. Increased afterload, chronic vasoconstriction and arterial stiffness elevate systemic vascular resistance, further straining the heart and worsening myocardial oxygen demand. Volume overload. RAS activation leads to sodium and water retention, increasing preload and contributing to pulmonary and systemic congestion. Compensatory mechanisms. Initially help maintain perfusion but become maladaptive, promoting ventricular hypertrophy, fibrosis, and progression to heart failure. Decompensation triggers. Decompensation triggers are factors that worsen heart failure, leading to acute exacerbations. These include myocardial infarction, arrhythmias, infections, or noncompliance with medications/diet, uncontrolled hypertension. Clinical presentation. Symptoms: a left-sided failure, dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea. Cough with frothy sputum. Fatigue and reduced exercise tolerance. Right-sided failure. Peripheral edema, ascites, and weight gain. Abdominal discomfort and nausea. Anorexia and cachexia in advanced stages. Signs: vitals, hypotension, tachycardia, and pulsus alternans. Cardiovascular, elevated jugular venous pressure, JVP, hepatojugular reflux, S3/S4 gallops, and displaced apical impulse. Pulmonary, crackles, wheezes, and pleural effusions. Abdomen, hepatomegaly, ascites, and tenderness over the liver. Extremities, pitting edema, cool extremities, and cyanosis. Investigations. 1. Laboratory tests. BNP and NT-proBNP, markers of ventricular wall stress, guide diagnosis and prognosis. Troponins, rule out acute coronary syndrome. Electrolytes and renal function, assess for hyponatremia, hyperkalemia, or kidney injury. Liver function tests, reflect hepatic congestion. Thyroid function tests, detect reversible causes like thyrotoxicosis or hypothyroidism. 2. Imaging studies. Chest X-ray, cardiomegaly, pulmonary venous congestion, interstitial edema, and pleural effusions. Echocardiography, gold standard for assessing ejection fraction, diastolic function, wall motion abnormalities, and valvular disease. Cardiac MRI, tissue characterization for infiltrative diseases, scar assessment, and more precise ejection fraction calculation. 3. Specialized testing, a right heart catheterization, evaluate pulmonary pressures and cardiac output. Stress testing, assess myocardial ischemia and functional capacity. Management, 1. Lifestyle modifications, dietary, sodium restriction, 2 gram per day, and fluid restriction, 1.5 to 2 liter per day. Exercise rehabilitation, supervised programs for stable patients. Avoidance of alcohol and smoking. 2. Pharmacological treatment, core drugs for heart failure with reduced ejection fraction. ACE inhibitors/ARBs. Beta blockers, e.g. carvedilol, metoprolol succinate. Mineralocorticoid receptor antagonists, e.g. spironolactone. SGLT2 inhibitors. Diuretics, symptomatic relief of fluid overload. Advanced therapies, angiotensin receptor neprilysin inhibitors, ARNIs. Ivabradine in patients with sinus rhythm and heart rate greater than 70 beat per minute. 3. Device therapy, implantable cardioverter defibrillators, indicated in ejection fraction less than 35% for primary or secondary prevention of sudden cardiac death. Cardiac resynchronization therapy, for patients with left bundle branch block and QRS duration greater than 150 milliseconds. 4. Advanced interventions, mechanical circulatory support, ventricular assist devices as bridge to transplant or destination therapy. Heart transplantation, definitive treatment for end-stage refractory heart failure. Prognosis and follow-up. 1. Prognosis, depends on ejection fraction, NYHA class, and biomarkers. Patients with recurrent hospitalizations or refractory symptoms have a poor prognosis. 2. Follow-up, regular monitoring of symptoms, biomarkers, and imaging. Early detection and management of decompensation through telemonitoring and outpatient clinics. And that's a wrap on heart failure. Thanks for watching. If you found this video helpful, please like, share, and subscribe for more medical insights. Drop any questions or comments below. We'd love to hear from you. See you in the next video.